I'd like to welcome everyone this morning to the DeBakey Heart and Vascular Center Grand Rounds. Just a few housekeeping things, as you know. So first of all, there are surveys in the back, and completion of these surveys are very important for us to maintain our CME accreditation. So please complete them and drop them off. Also, too, as you know, we're live streaming this. Actually, we're live streaming this and the re-evolution course simultaneously. The importance of that is when you have questions, please do use the microphone so that everyone following from around the world can keep up with what we're saying. So this morning we have a real pleasure to bring some international talent from Canada down to Houston. Dr. Marc Ruel and Dr. Ben Sohmer and Ed Jordison are here from Ottawa. It's a real pleasure to introduce Marc. I've known Marc a long time. Marc is probably one of the highest regarded and admired heart surgeons in North America, if not the world. He's the Michael Pitfield Chair and Professor of the Division of Cardiac Surgery up in the University of Ottawa. Ben Sohmer is an anesthesiologist at the University of Ottawa. He did some training at the Cleveland Clinic. Today they're going to talk about the developing and implementing of minimally invasive cardiac surgery procedures, a team-based approach. So looking forward to hearing from it. And I think we'll have Dr. Ruel come up and get started.
Good morning. Tom, thank you so much for your very kind introduction. It's really a pleasure to be here. I think we've had strong links with Methodists over the years, and certainly we have a lot of friends here, Mahesh, Tom, Ross, Alan, and others who I'm sure I'm forgetting, but we've been privileged to come to your institution several times. We feel that we have academically exchanged not only through the re-evolution meeting, but Mahesh and his team was in Ottawa for some mixed Cabbage cases. We were here for some mixed AVR cases. And it's always been like a very strong relationship, and one that in which we have full confidence, and certainly one where we can talk about pitfalls of research and technical development and education. I would even add that one thing that certainly we learn a lot from the Methodists is your tremendous emphasis on education. I don't think there are too many, if any, institutions in the world who are second to yours with regards to its dedication to education and surgical education, shall I say. And your facility is impressive. And because of this, today Ben and I and Ed took the care and the attention of bringing 3 of our trainees. So we're kind of overtaking Houston in a way. This is one of the largest Canadian contingents in years of having 6 people from one city go to another country. So we're very pleased to have been invited. So what we thought we would do today is Ben and I will talk about developing minimal invasive surgery, and we'll focus on cardiac surgery and incidental or coronary surgery. The same example could be said of mixed AVR, invasive mitral valve repair, or other types of procedures that are minimal invasive. But let's, for the sake of example, use minimal invasive bypass surgery, knowing how important it is in the landscape of coronary vascularization, how infrequently performed it is, and how difficult it is to perform. And I would say, I just want to give you an overall view of where this operation is at and how can you team develop it. I'm speaking to Converted because I know you have a mixed Cabbage program here and a successful one, but I think all of us could develop mixed Cabbage to even much beyond where it is right now. So let me tell you a few things about Ottawa. Ottawa, I'm sure many of you have gone to it. It's the capital of Canada. It's a very nice city. It's one of the G8 cities or G7 cities that has the most green space in it. There's also the longest skating rink in the world, which you just saw. It's called the Rideau Canal. It's something like 10 miles, or correct me if I'm wrong, Ben, 10 miles long. There's a constellation of rivers going through the city, and overall it's a very livable city. And Ottawa was unique in our country that it was the first city with Montreal to have a heart institute, and the heart institute model was developed. And it's not a virtual heart institute, it's actually a physical heart institute where research, education, and obviously clinical care are put under the same roof. And that roof is a separate one from any general hospital, entirely dedicated to cardiac care. So that model has worked well, and I know it's been emulated in many countries of the world, including yours. The main difference, I guess, between Canada and US, apart from the overall population, is the fact that we don't really have certificates of needs, but it takes a lot for a cardiac hospital to develop itself. I was speaking with Danny Becancourt yesterday, who was telling me that there's 150 cardiac programs between LA and San Diego. I don't imagine the population of this area between LA and San Diego is 300 or 400 million people. But certainly Canada being 35 million people, we have about 35 programs or so. So about one program per million. Ottawa being a large program, we catch an area of about 2 million people with regards to surgery. We do about 1,700 open heart surgeries per year. And the territory that we catch here is compared to the superficie of France, the area covered by France. So you can see it's a huge territory, and not infrequently we'll operate on Inuit patients as well. So there's no question that Cabbage is a great operation, and this is just a depiction of the 5-year results of the Syntax trial published by Fred Moore a couple of years ago with the Lancet. There's many ways to look at this. This is our own study in the Lancet as well, looking at 5 years data in diabetic patients who underwent PCI versus Cabbage, and the mortality benefit is about 50%, or 1/3 less, or 50% more patients alive, if you will, whatever way you look at it. Noble and Excel have created a lot of buzz recently. These two trials, if you know, were quite awaited, and there's nothing on the horizon for the next 5 to 7 years. So this is the data that we'll have to live with for probably the next 10 years or so. And what's interesting is that the Excel trial finished at 3 years and had a different definition of peri-op MI than Noble did. But once you take this out, essentially, and this definition has been hotly debated, if you will, but once you take out the peri-op MI, which previously had never been hypothesized as a major source of difference between Cabbage and PCI, once you take this somewhat arbitrary definition, the curves with regards to MACE, whether the hard MACE without target vessel revascularization as it was in Excel, or all MACE including target vessel revascularization, the curves essentially are the same. And the world's looking forward to seeing the 5-year results of Excel. This being said, patients are not in love with coronary bypass surgery the way it's done today, because patients, there's no question that they want less invasions. And I say this to our trainees, it will be a sad day if we're in 2040, 30 years from now, or 25 years from now, in the midst of their career, and that their main coronary revascularization operation still involves going zzz with a saw and opening the sternum. To me, this is retarded, and something has to be done to get away from this operation. And society certainly has done it already. Patients have been willing to accept suboptimal outcomes in order to avoid major surgery. And the Syntax trial, just as one small example of this, there were about 5 times more patients withdrawing consent, wanting to go in the PCI group than in the Cabbage group than in the PCI group going to Cabbage. Can you put a number on this? Yes, you can. In fact, the quality of life that's been looked at after Freedom and Syntax and many other studies, but it's interesting to look at these two together because they're the two largest ones that have compared quality of life after PCI versus bypass surgery. And essentially, when you see a patient who's about to undergo bypass surgery with the currently available means, sternotomy, whether it's on pump or off pump, the price to pay is about 6 months. And you can see it here with regards to angina frequency, which starts being superior for the Cabbage group after 12 months. But the physical limitation, and the red rectangle here shows the detriment that Cabbage brings for the first 6 months with a significant p-value. And that detriment actually reverses somewhere between 6 and 12 months because of the enhanced freedom from angina. And essentially, you can graphically depict this here with the full dots being Cabbage and the empty dots being PCI, how the quality of life lags for about 6 months, and then after 6 months, largely because of the better freedom from angina, Cabbage becomes superior. So everyone talks about progress in bypass surgery, but to me, bypass surgery is still performed this way in most centers, and the vast majority of operations are. And there's a problem with this. You know, if you look at the evolution, or so-called evolution, this was the operation in 1985, and you add 1 or 2 internal mammary arteries, and you have the operation performed now. So it's hard to know which way we are, towards the head or towards the tail. And certainly our premise about 10, 12 years ago was to try to develop a less invasive operation that would preserve the safety and effectiveness of bypass surgery, not change the operation, but try to do it less invasively. In a nutshell, what this operation is mixed cabbage. I think you're all acquainted with it. It's performed at your institution. It's increasingly performed in the world. There are probably thousands of cases being performed on a yearly basis in India, and many hundreds in Japan and other parts of Asia. Canada is doing well with regards to it too. It's slowly taking on. The US is somewhat lagging, and I think part of this may be the medical legal context, but also the physical habitus of the patients. This is not an operation that's easy to do if your subject weighs 400 pounds. So this might be also one aspect to it. But it is one way to try to hit this problem. And certainly the premise for the operation is that by placing a well-chosen thoracotomy about 1 intercostal space above from the apex of the heart, one can access all the major myocardial arteries as well as the leta and the ascending aorta for proximals. What you need essentially is a good retractor system. I'm not going to delve into detail. You need a low-profile epicardial stabilizer. There are several companies providing those. You need an apical positioner, and essentially you need a well-placed thoracotomy so that you can go from this kind of exposure to do proximal anastomosis to, in the same patient, what I call an intermediate exposure, and then this determined circumflex exposure to perform a marginal graft without any issue, all through the same incision, same intercostal space. And it is feasible to do so, and it's routinely performed. I'm now going to switch to my colleague, Dr. Ben Sohmer, because one very important key aspect of this operation is that you need a team to develop it. Part of your team is your nursing team, your trainees, and the overall philosophy of your institute or hospital. But you need a very, very solid person at the helm of this operation to maintain the hemodynamics. In fact, the hemodynamics are more difficult than what I would call an open chest off-pump surgery, because the heart doesn't really have anywhere to get out of. If you look at off-pump surgery, you'll notice that often the apex of the heart in the LV is above the level of the sternum. So imagine this translated to a closed chest type of operation. You don't have the same capacity, and you need a very strong anesthesiologist, not only to make the surgery easier, but also keep the patient solidly arranged during the operation. So this is a picture of Ben. One day I've asked him to wear a full face mask. He came back and he put a tape with his name on it, just to make sure that I would recognize him. So one of the multiple jokes that he performs in the OR that successfully relax the team and make sure the patient is well taken care of. So Ben?
I'll start by saying that I do in fact know my name. I don't need a name tag. And Marc doesn't know this, but June 1st will be 10 years that I've been working with him along his team, and in that 10-year period, we've done a great deal of evolving and reinventing and growing of our program. So the emphasis of what I want to talk about is how do we see development and implementation of a program from a different perspective. So with any curriculum development, any program development, it always starts with a design and always starts with a needs assessment. And we're going to make the assumption that the patient always comes first, which should be the case. And we have to look what's important for the patient. And from an anesthesia perspective, we go through the A's of anesthesia. They need to be relaxed with anxiolysis. They need to have analgesia. They need to be asleep. They need to be, of course, alive at the end, and so on, and, you know, and amnesia to not remember. Same thing goes with the surgeons. Sorry, where's the, which mouse were you using, Marc? This one? Mouse. Okay, I got it. Same thing with the surgeons, where the A's of surgery is you want to have an anatomic correction. They're coming there for an anatomic problem. You want to fix it. Patients want to get back to their normal lives. They don't want to be sick. They want to be how they are, how they were before. To a certain degree, depending on the demographic of the patient, they want nice aesthetics. And of course, again, they want to be alive at the end of the case. in cardiac surgery, depending on the center you're at, you're looking at a reasonable percentage of mortality when compared to the general anesthesia or a general surgical population. We're in the big leagues here. From a surgeon's perspective, surgeons need space, surgeons need exposure. They need to have their patients satisfied and happy regardless of what system they're in. They need to make their hospital system happy regardless of what system they're in. And of course, everyone wants to do things as easy as possible for them, despite the fact that these type of techniques are becoming exceptionally more challenging as they become minimally invasive and as technology advances. Surgeons as well look at the A's of anesthesia because they're important to them. And I'm assuming that most of the room here are filled with surgeons, and these are important, but they're not your primary concern. When we look at what a surgeon needs really from us is, don't have the patient talk to me and don't have the patient move so I can do my job. And we appreciate that in anesthesia. We work in a socialized healthcare system, whether it's socialized, where it's all done with one payer, which is the government, or whether it's a private system like you have here with the abundance and the density of hospital systems within a very small area. We're all here to ensure that we're most efficient in running a business properly. The system needs things. The system needs patients to be out of the hospital as efficiently, as effectively as possible. The system needs to have the minimum amount of infection rates. We respect that too, and if we can develop techniques and apply attention to detail that minimizes these risks, we all benefit from it. So now that we have a needs assessment, we know what we need. What's our big problem? We know what we need. Our problem is we want to do things to a very small hole. And that isn't easy. And I'm not a surgeon, but I can appreciate that that isn't easy. So I use minimally invasive techniques using the following analogy. No patient comes to the hospital ever for an anesthetic. Perhaps Michael Jackson, but that's another story altogether. They come for the surgery and the operation. And the operation, I compare to, from a male perspective, to a Hugo Boss suit. It's an absolutely totally beautiful suit. It's well tailored. The material is perfect. It fits nicely. That's your operation. It carries the room on its own. And that's really what the minimally invasive stuff is. What do I do, or how I can add to that as an anesthesiologist, is I can make that suit and I can make it better. Just like BASF, we don't make things, we make things better. So how can I do that? Well, we go back to the analogy of the suit. Get a nice haircut. Sorry, I don't have one. Nice tie, nice cufflinks, polish your shoes, and all of a sudden that suit, which was really nice to begin with, is even nicer now. That's the role we play in anesthesia amongst all the others. So now we look at a team approach. I'm biased now. This is my team. The Ottawa Center is the hockey team. And my other bias is, that's my guy. What does he do with the Ottawa Senators? Happened to be on the ice with them once. But the reality is, even the smallest little 9-year-old can play a role with the big boys. And that's what we try to do with every single member of the team, whether it's the surgeon, the anesthesiologist, and all the associated members in the operating room. So I tend to be a bit of a direct kind of person and a little bit blunt, and I'm not going to ask anyone to raise their hands, but we all know in this room our internal biases that if heaven forbid any single one of you needed an operation, I would ask you in your heads to think of the top 3 people you would ask to perform the operation. You all have that answer. And if I ask you that same question, who would you not have to do that operation? The same thing would hold true. And the same question would apply to anesthesiologists and so on. There was a group in New York, this is several years ago now, that looked at cardiac surgical registry of tens of thousands of patients, and they eliminated all the they matched all the variables and excluded only the anesthesiologist. The data has since been re-examined and probably maybe a little bit flawed, but I'm using this for the purpose of exemplifying bias. But the anesthesiologists were actually categorized into 2 groups, high performers and low performers. They showed statistically, again perhaps flawed, that the anesthesiologist does matter. So the skill of the physician is in fact true, and your all internal thoughts of who you would want to do your procedure or who you'd want to deliver anesthetic is probably in fact true. And with all due respect to industry, whatever retractor, new suture, new device is probably way less important than the true variable, which is the skill of your physician. And another analogy to that is, if I were to go play golf with, we'll say Tiger Woods, and we had the exact same equipment on the exact same course and the exact same conditions, every single time he will do better than me. And the only reason why is he has more skill than me. And measuring skill is very difficult to do, and it's an institution like this with a high emphasis on education is where we're actually going to get to that real answer. So the solution here is develop a team. Get your team together so that we can all work together to come to that final, the final major outcome of what our needs are. So how do I view myself as a member of that team in the operating room? Well, I take my A's of anesthesia and I add on another one, which is assist. So yes, we have, if we're here, we may have PAs as your first assist. You may have a resident as a second assist. I'm also an assistant, and I actually can do things other than just pass gas. So let's make fun of anesthesiologists, the A's of anesthesia. We've got to make fun of ourselves. Arrive, breakfast, coffee, donut, excavate floor, go home. Boom, we're done. We are, in fact, more, or we can be more. This goes back to the skill. We can be more than just the clear syringe and the white syringe. We're more than that if you want to be. So I want to redefine, to a certain degree, the anesthesia alphabet. Although I will keep the first one because I kind of like it. As an assistant, I can help in big domains. I can help with exposure. I can help with positioning. I can help optimize physiology, and I can help with hemostasis. So just out of curiosity, how many are surgeons in the room? Okay, residents? Doesn't matter. So if we look at this picture, this is Dr. Ruel. He's wearing the loops up here. Where is it? Where's the mouse? No mouse. He's the surgeon with the loops on the left. Just to make note, this is a typical operating room. This is what we normally look at, right? My colleague, the anesthesiologist, he's not looking at the patient. We have an assistant, we have two assistants and a surgeon all looking down at the patient. That's their perspective. The anesthesiologist is looking at a different thing. They're looking at the monitor. It exemplifies that we see things from a different perspective, we see things a little bit differently, we interpret it a little bit differently, and we're aware of the environment a little bit differently. And if we optimize that, hey, we can actually do things. We can actually make little changes and address and be those cufflinks and be that tie in the operating room. Be used for breathing. Most, if not all, of these techniques require one lung ventilation. Depending on your institution, your preference, you can use double lumen tubes, you can use bronchial blockers, but it's a factor that we have to think of because it's a technical issue. I tend to go with what's comfortable. I've tried all of them in all different procedures, and a lot of it is trial and error. The kicker, though, is it's hard to, well, maybe you can see it, but for those who have used double lumen tubes or have seen them, industry has created little things to fix our physiology, like CPAP devices that fit beautifully onto double lumen tubes. They don't work on bronchial blockers. When Dr. Ruel does his mix Cabbage, the technique of choice is a bronchial blocker. We can't do CPAP on that. Well, use a little innovation, be Canadian, figure out ways to do things that are right down the middle that work, and you jerry-rig a 3cc syringe, and all of a sudden that thing can work. So be creative and express your creativity in trying to figure out problems and solutions, and lo and behold, they can work. Breathing also has to do with lung physiology. For those who do thoracics, and I'm sure there are a bunch of thoracic surgeons in the room, the physiology for one lung ventilation when you're in the lateral position is actually quite nice because all ventilation and perfusion preferentially goes inferior or with gravity. When you apply that now to the cardiac patient, whether it's supine, you now have a big problem because again, everything is going down to the gravity, to the ground, and you're actually missing an entire lung. So lung physiology, especially at the times of CPB weaning, can be very, very challenging and very problematic. And when you add on shunts and so on. So the physiology, though in the textbooks is the same, is actually in fact different because of how the patients are actually positioned. I also use C for the purpose of circulation. The smaller the incision gets, the less a surgeon can touch and feel and see. So we have to use different mechanisms for seeing. I happen to be an echocardiographer because it's 2017 and cardiac anesthetists also image. Imaging allows me to show the surgeon what they want to see. So with cannula positionings, when Dr. Ruel does his cannulation from the groin, he doesn't have to feel the SVC or IVC to see where that venous cannula is. I show him and I show it to him on a picture. And in time, that trust becomes there, and he doesn't have to feel it. He knows. We also are there, C for circulation for hemodynamic support. Depending on what you're doing and what you're cannulating, the RV can be somewhat problematic. The RV is a fairly anterior structure and gets in the way. Depending on the part of the technique, so for example, in the mixed Cabbage technique, the proximal anastomosis on the ascending aorta, the way the heart is positioned actually causes compression of the RVOT. Big deal for the surgeon, not really, but it really messes up, especially if it's off-cab basic physiology, because we're creating iatrogenic, equivalent to iatrogenic pulmonary stenosis. We see that with echo as one example. In addition, we have this big RV that's sitting anterior in the chest. How do we make that easier for you? Well, I'm not going to overload them with fluids. I'm not going to make sure that CVP is high. And you need be, even in a normal heart, I'll add some inotrope in to offload it. It's just, it's not rocket science, but it's just outside the box thinking of little small details that facilitate it. Dr. Ruel almost never has an RV that's popping out of the chest. It's gone. We know that from the word go. The other key issue is something that it's a game that I play in the operating room, is to optimize communication. And we hear that all the time, that communication is key. But the game that I play routinely is there's not a surgeon in the room or a surgeon that exists who doesn't always look up at the monitor to say, look at the blood pressure, look at the vitals. It's part of the nature, it's part of the training, and it makes sense. I have optimized, granted this is over 10 years, the game that I play is, I can tell from his tone of voice, the stage of the procedure, when he's about to look up at the screen, and I actually preempt it. And I'll tell him his answer before he asks the question, and guess what? His head never pops up. So if his head never pops up and his neck hurts at the end of the case, I've succeeded. These also I'm going to use for analgesia, but it's important and key if you take analgesic or anesthetic cocktails and concepts from the non-cardiac OR and we apply them into the cardiac OR. It shows my age, but I'm getting old now, but the days of massive opioid administration for cardiac with nitrous and keeping people asleep for 7 days is long since gone. And early extubations and fast tracks, which I'll talk about later, are becoming more and more where we're striving for. One of the areas that achieves that, especially in thoracics, for those thoracic surgeons here, are the use of multimodal analgesia and regional anesthesia. And it doesn't make a difference what you use. If you're pro-epidural, use epidurals. If you're pro-spinals, pro-spinals. Paravertebral blocks, on-cue balls. The literature will not support any of it. But we all know that when we add it all up together, our patients look and feel better, and that's good enough for me. So when we go into the multimodal concepts, throw in your NSAIDs, throw in your anticonvulsants, throw in your opioids, and keep them low to minimize their side effects. Add in your Tylenols. They all work, and they all work together synergistically, and it's not going to be found in a journal, but we all know that it's true. And if you have a bias that an on-cue pain ball works, use it. It works, it's right. And again, just to sort of bring it together, that minimally invasive surgery always results in maximally invasive anesthesia. It is a much bigger pain for us in our field to provide care for this. You have to make sure that the people who you're asking to provide this care are on board and are interested and believe in the product. I happen to be one of those people. D I use for details. Anyone can do the anesthetic. It's not the most difficult of anesthetics to do. Not everyone can do the anesthetic well. And the difference, I believe, in doing it regular to well purely comes down to the minute details. If you take care of all of them, the sum of the parts actually does hold true. With respect to exposure, this is a kicker. This is a real key one that we've been working on for years. This actually, it might even be 8, 9 years ago, where at the early onset of the mixed Cabbage, when Marc was trying to figure out the best way to do his proximals on the aorta, it was quite deep. So we said, oh, okay, it's quite deep. Why don't we bring the aorta closer to you? And he looked at us with, like we were crazy. And we said, well, we can do that. And again, if we go back to basic physiology, if you have, for the mixed Cabbage, if you're having a thoracotomy incision, we basically have a large pneumothorax. Why don't we take advantage of that? For the most part, pneumothoraces are thought of as complications. I don't see it that way. In the operating room, in a controlled way, we use it to our advantage. Why don't we blow up that whole pleural space with air? And why don't we push that aorta towards where we want to go? It's the exact same physiology, it's the exact same mechanism as cardiac herniation post-pneumonectomy. And if we look at a CT scan, we'll look at that. Our left chest is full of air, and look where our heart is. It's right there in our incision where he's working. So we actually said, geez, this is interesting enough, but not interesting enough for a journal, but we measured it. And if we looked at our holes on the left-hand picture, you're looking at a couple centimeters deep to the structures you're working on. We manipulate the physiology a little bit, and instead of pulling, we're actually pushing, and sure enough, the heart comes right into space. Dr. Ruel does not use knot pushers. He uses his fingers. And he doesn't have fingers that are 40 centimeters long. He's using direct fingers only because we bring everything to him. And with a fellow 2 years ago, we actually measured it, and there was a statistical significance in the drop of the depth was actually decreased, which was nice to see. Does the literature really care? No, that goes back to what I was saying before, but is it important, and does it minimize the challenges and difficulties that the surgeon will have? Absolutely. I'm not going to do that. F is a key one. It's a fast track and fast start. Okay, whoever works in an operating room, who's worked with a slow anesthesiologist, who gets frustrated when they're slow, who likes the fact that you're on time. So I take that, that's the key. I'm really into that. I find that also one of my challenges. Be quick. All of these techniques, whether it's admitted, spoken of or not, always take longer. So if the whole thing takes longer and we can save 20, 30 minutes on either end, well, look at that. That's an hour in the morning, an hour in the afternoon, and our numbers aren't that bad. You have to be fast and efficient. And for me, it just means I get to the operating room a little bit earlier to make sure of that. Not difficult to do, but again, it's focused on details and minimizing issues. The next thing, especially because we're an education center, is metrics. Are we doing it well? Is it good? How do we measure it? And these are things that will come up, and you will look at hospital length of stay, and you will look at cost to the system, and these are things that will be essential to measure and to see to support what you're doing. Where I'm looking for it, I extubate most of my patients on the table because there's no reason not to. If they're awake, if they're warm, if they're pain-free, if they have no delirium, if they don't even need an ICU, I see it very reasonable that a good section of these patients can go straight to a step-down unit. And that's one step closer to getting home faster. And all of a sudden, the insurance companies like your center other than other centers because you're more efficient and you're cheaper with good metrics for it. So I bring you back again. The operation is the Hugo Boss suit. It's great on its own, and it will thrive on its own. If you want to bring it to the next level, make it nicer with all the small details. Back to you, Marc.
Ben, this was great, Ben. Thanks very much. And Ben has been tremendously helpful in setting this up. And there's also the aspect of when you have someone who is as engaged, but it's not just the engagement, there's also the competence and the effort that's being put in trying to make that surgery and that anesthesia and that overall operative experience simpler. It reflects on your entire team. And our nurses certainly feel the pulse of this, how these cases are important. And I think we could have also added a nurse to this presentation. Ed is here, Ed Jordison, who's our care facilitator. But it's very important when you start that your team is kind of a tight holding unit. You know, you're a little bit of a sailboat crossing the ocean, and you're in it together. And don't make you all know this, but don't make the team too wide at first, and make sure you have your key people. And now I would say a testament to Ben's approach and the success of this approach is that unfortunately, we seem to not be doing all these cases together anymore. It used to be like that, but now it's spread out to everyone because it's become complete routine. And I don't think the schedule gets looked at if there's a mix, a Cabbage planned for Monday and Tuesday or something, with as much scrutiny as it did a few years ago when it was more of an intrinsic team. Anyways, a couple of things around post-op care and results, and this will conclude the presentation this morning. Post-op care with this operation is simple. There's a couple of things you have to watch for, which these patients tend to have, because they recover faster, a bit more sympathetic drive, in my opinion. And when they go into AF, they go fast. They have a rapid ventricular response. And you also have to watch for a left pleural effusion, which typically is inflammatory in nature as opposed to hemorrhagic in nature, and will often occur around day 15 post-op. So be wary of the patient who calls you back and tells you that they're a bit short of breath. The first thing to do is obviously an X-ray. With regards to pain, the pain is no less with a thoracotomy, even if the thoracotomy is very small. The pain is there definitely, and I think on post-op day 1 to 3, it is equivalent to a sternotomy patient. On post-op day 0, usually they have very little pain because of the intercostal blocks and etc. But the major difference is that the pain goes away quickly. If you were to schedule a design a randomized control trial of minimal invasive bypass surgery versus conventional sternotomy bypass surgery, I don't think you'd see much difference in hospital. You may shave a day of length of stay or so. But I think the main difference would be what these patients are able to do at 1 month, the kind of 2 weeks to 6 months period, which is tremendously improved. And then we're actually designing a trial around this right now. If they're performed off pump, which is the vast majority, I give them clopidogrel. The other thing is around the chest tube. For those who are interested, the duration of leaving the chest tube in, I've played around with taking it on the day of surgery, taking it out, leaving it for a couple of days, 1 day, etc. I'm now routinely leaving the chest tubes in for 3 days. So typically patients have their tubes in, a flexible Blake type chest tube, left in a single chest tube for 3 days, and then it's removed, there's an x-ray done, and they go home on post-op day 4. So one example, I mean, an image is very telling. This is a patient who had 4 grafts performed to each major myocardial territory plus a diagonal. So the PDA was grafted, the OM2 was grafted, the diagonal, and the lethal LED. Another patient, this in fact was our first patient back in 2005. He had a triple Cabbage performed. Joe McGinn has been a co-developer of this, and Joe is here for the Revolution Methodist meeting. Joe is a fantastic colleague and friend over the years. We've collaborated. We kind of, in a stepwise fashion, developed part of the technique together. Initially, we put our data together back in 2009. There were 450 patients, well-chosen patients, a lot of double Cabbage, a lot of patients with double coronary disease, about 50%, but still about 1/3 of patients who had triple vessel disease and received 3 grafts or more. Later on, from our own in-house series, we looked at case matching 150 of my patients who had mixed Cabbage versus some of my op-cabs, 150 median sternotomy op-cabs, to see if there was a difference. This was a single surgeon series with the limitations that come with that, and they were matched on LV function and the number of distals and age as well. What we found basically is that the main differences are not in any of the hard outcomes, but with regards to freedom from wound infection, essentially with mixed Cabbage, you don't see a deep wound infection. Since then, I've actually had 1 deep wound dehiscence in a patient who was 85, took care of his spouse who had Alzheimer's disease, forgot to eat for a week, and basically just was completely catabolic, and his wound fell apart when the suture degraded. And that was treated quite conservatively without too many issues. But essentially, you don't get infections with this, and the median time to return to a full physical activity or questions to our patients were to ask about freedom of movement in both lower and upper limbs was only 12 days in mixed Cabbage patients. The other interesting thing is that we don't, with our physios, we don't give them restrictions post-op. They're allowed to use their hand, get out of bed, push on the bed or on the railing, and do what they need to do. We also, some questions were raised around patency of this operation. There's no question that it's not to be put in all hands. As you know, there even have been patency issues around a simple sternotomy off-pump versus on-pump Cabbage. So you can imagine that when you multiply the difficulty by doing it through a small incision, patency can become an issue. Fortunately, in this 100-patient or 90-patient case series, patency was excellent. We had a systematic follow-up prospectively in a dedicated study realm for this, and we had 92% patency for all grafts. Yet, I must say that in my career, I've reoperated 2 mixed Cabbage patients who came back with significant issues with their coronary grafts, and I don't think I've ever done this for a sternotomy Cabbage patient. So there is a learning curve, and I have made probably what were technical mistakes. I don't think around the anastomosis, but around leaving the grafts too long. And I think I sinned, I erred on that consideration of leaving the grafts, avoiding having a short graft, and I think you pay a price for it, especially when you come from a thoracotomy point of view. Even though you niche it in the pericardium, there may be some pressure from the lungs and the way that the pericardium heals that eventually may take the graft away. So learning curve issues that over the years, and now 12 years, we've gone over, and overall very, very good results. And again, the beauty of this operation is that the configuration of the grafts is exactly the same as a regular bypass surgery. So we're not talking about a Y graft base with veins coming in T fashion from letas, et cetera. No, it's good old proximal anastomosis on the ascending aorta and distal one independent graft per myocardial territory, if that's the way you see a bypass operation. And I would add that this is the validated way that the bypass operation works. Essentially, in all the studies, you go look at syntax freedom, et cetera, they're not Y or T-based operations, but they are independent grafts using vein or radials or et cetera. So another example of this on CT scan. And essentially, to conclude, the mixed cabbage is also growing in acceptance. What's not important, I always say, it's not that we do the operation, but it's that others do. You guys do it as well. But the point when I have teams visiting, and I always encourage that they come as teams, that they bring an anesthesiologist, a nurse, and obviously a couple of surgeons, and that they then start with a case early after their experience. And that's been the most successful approach. A little bit like what happened with TAVI in the past. And what I would say is that the most encouraging sign is not that we do it and we publish around it, but rather that other groups are publishing from Japan to Russia to India and other areas in the US, publishing. This is just one example in 2015 on papers that have come out in our main surgical journals on mixed cabbage and its techniques. So I don't have a formal conclusion slide because I think Ben provided this to you, but again, I think on his behalf and mine as well, we wanted to thank you for the wonderful invitation today, combining this with your tremendous re-evolution meeting, again, establishing the leadership of the Methodist in terms of surgical education. And I want to thank Tom and Mahesh for taking the time to invite us at this wonderful venue. We'll be happy to take any questions you may have.
Thanks very much, Marc and Ben. Before we start the questions, I do want to make an announcement. Tomorrow, the Gills, Linda and Jack Gill, who are well known to the Houston Methodist community, are going to get an award, the Dai Shen Wong Community Service Award, and that will be presented to them tomorrow at the Re-Evolution course at 11 a.m. And we really encourage everyone to attend. So again, this was a great presentation, Marc and Ben, and I think that what you both have demonstrated was that cardiac surgery is the quintessential team sport, and when done well, the patients do very, very well. My question is, you know, teams don't just happen overnight. How do you choose your team? How do you get your team to practice and roll out these very complex procedures? Can you kind of walk us through that?
Thank you. It's an interesting question. I'm going to answer it from a different perspective. I'll start by saying the reason why I'm on this team, to be totally blunt and honest, is I personally had an interest in it, and probably more importantly, no one else in my group wanted to do them. So it's a matter of it goes back to leadership courses where you identify your stakeholders and you see who's interested and you try to build up and gain interest. If a surgeon believes in a product or a salesperson believes in a product, if you sell it properly and you say this is good for these reasons, you'll get people on board. And it's a very positive way to address team building. I saw his operation. This is interesting. I have a skill set to work on it. Let's figure this out together. And of course, there's mutual respect, and the list goes on and on. But it's selling what you believe to be true, get stakeholders and interested people on board, and that's how it starts. It's picking people in the schoolyard. I'd like, you know, him, her, and her, and that's why. That's how I see it.
It's a great answer. I don't think I can add much to it. I would say, again, as Ben stated and was recalled earlier, bring your team to train. This is whatever new procedure you want to do or develop, make sure that it's not a monolithic approach, but it's really a team-based approach. And then I would add, from a purely psychological engagement point of view, the first 3 cases are tremendously important. You want to do these in relatively close succession, ideally with a proctor. And I'm not speaking to Methodists here. I'm not talking about general principles. Obviously, you do this already. But I think for you, the institutions that visit you, that want to learn something from you guys, I think that's one of the key recommendations. If there's a way that they can even be proctored, and always come back to the TAVI example. You know, TAVI is not nearly as intricate from a technical point of view as this is, but yet it has to be done well and it has to be standardized. And if it had been cowboys, and no pun intended being in Texas, but if it had been like people being somewhat cavalier right and left doing TAVIs and exploding aortic roots and femoral arteries and iliacs on stick too often, I don't think the technology would have developed the way it is. So the companies were very, very strict in proctoring 15 cases before a team could be solo. They were very adamant about training teams and not individuals. And I think those principles were well laid out. And we can learn from industry, and industry can learn from us. And I think that's also a partner to include in your team.
One of the things that when I was looking at your slides of your postoperative patients, looking for the incisions, I thought that maybe I needed a new pair of glasses because I couldn't really see anything. You know, it is truly minimally invasive surgery. But I guess one of the reasons, Ben, when you asked for a show of hands of surgeons, and not everybody raised their hands, this is a group of surgeons, cardiologists, anesthesiologists. And so I guess for the cardiologists in the office, they'd say the quintessential minimally invasive procedure for coronary disease is PCI. Here's your chance, Marc, to make a pitch for surgical revascularization over PCI.
No, I think this is too big of a question to look at. But remember, what we're doing is we're giving new arteries. We're replacing an artery. We're not focusing on the diseased artery or the disease portion. And obviously, we could talk 3 days about this, and I would actually love to do it, but at a different venue. But we have, you know, of all the great fields of surgery and interventional or structural cardiology right now, you look at heart failure, valves, aortic, and coronaries. The one field, I would argue, that is the most different from a pure ground-up point of view in terms of its approach to dealing with the disease is actually the coronary field. If you look at what's being done in valve surgery and aortic surgery, it's not that different between endovascular/interventional approaches and the surgical approach. But in surgery, it is tremendously different because of that concept of providing a new artery, especially an arterial graft, which may have its roles not only in terms of durability, but also in curtailing the progression of native coronary artery disease. And I think that's the next area. And I didn't go too much into this, but we are now working on ways to do this operation as a total arterial operation. We can do 2 arterial grafts, but we cannot do 3 or 4 easily. There are ways, but it's painstakingly long and difficult. For instance, harvesting the right mammary artery is not easy through a simple thoracotomy approach. But it can be done, and certainly I think that's the role of the robot. And the robot, in my opinion, is not to craft distal anastomoses or do this or that, the very technically intricate aspects of this operation. But in terms of harvesting conduits, I think there's a beautiful opportunity there. Then you have 2 memories. You can put the right on the LED, you can put the left on the left system, you can put a radial either as a Y or T from one of those or from the ascending aorta, whatever you choose to do.
Thank you. You guys see a role for preoperative imaging for preparation, especially if it's a redo case or, you know, just seeing the technical aspect of the procedure?
This is a great question. I don't use it personally, but I recommend that people use it. I would say I've done so many that I can find my way around, unless I were to come and find like an old TB with you know, chronic inflammatory pericarditis and pleuritis, et cetera, with a 4 millimeter pleura. I think it would make it a little bit more difficult, definitely. And I'm not sure a CT would necessarily always give me the answer from that point of view. But in terms of positioning, we've used non-CT based ways to do this. My problem with CT, I think it's very promising, but is that when we position those patients, and I didn't go into the technique today, but we use a 15 to 30 degree decubitus, we bring the arm up, we bring the lung down. When you do a CT scan, you don't have these considerations. You cannot do single lung isolation and then ask the patient to undergo a CT scan. So things shift a little bit. And to me, the best CT is going to be like a Zigo type of system where now you're positioned, you're ready, you think, I'm going to go here, I'd like to know where the mitral valve is, where the aortic valve is, where the apex of the heart is, where do we see the LED. And then you come in with a fast rolling type of C-arm, CT-like capability and determine, okay, I'm going to make my incision right there. Knowing this once the position is, when the patient is positioned, prepped, and ready to incise. And I think that's going to be very powerful because then there won't be any mistakes and there won't be any transfer parallax between what the CT showed 2 weeks before and what you have in the OR today.
It's actually a little more involved than that, is that anatomy, physiology is what we learned from day one, structure, function. He referred to structure. I think of function and physiology. There is some information that imaging can provide. And for cardiac, the workup for physiological baseline is different than thoracics. We don't necessarily in this day and age have smokers. We don't have emphysema that the typical thoracics patients have. So interstitial disease, the ability to oxygenate and so on is actually useful to us. So yes and no is the answer to your question.
Well, thank you very much, everybody, for attending.